could just raise her hand, and her father are here, and they've had some really phenomenal success. Adriana had something where she was hypersensitive, and after having the splinting, it's really helped reduce that sensitivity. I also have a friend of mine from business school who had a situation where she had MS, and all of a sudden the symptoms went away. So it's been, and it's not just for a temporary situation, it's gone over through the period of time for several years that the symptoms go away. He's been doing it for over 25 years, and what he's realized is the trigeminal nerve has such great impact to the rest of the body. And he's going to come and talk about it. Thanks, Dwight.
Thank you, Christine. Well, I appreciate the opportunity to speak to all of you here tonight. We'll try to make this fairly quick. I know it's getting a little late. And I have a number of other patients here too, which we'll have them. Hopefully I'll have an opportunity for them to speak a little bit when I finish here. I graduated from 1976 from dental school in San Francisco. Shortly thereafter got into doing European type orthodontics. For the last, since '86, my practice has been limited to oral facial pain and orthodontics. So I do this on a full-time basis. And what we're looking at is you look at faces. Faces are a very important part that we focus on. A lot of my theories that have developed also get back into a lot of primitive skulls and primitive bites. I developed a number of theories based on what we call biomechanical principles of occlusion that aren't within the understanding of dentistry. I haven't really published these yet. But the principles as we treat pain, pain patients are a particular kind of patient, and they teach you that you have to do things extremely precisely. And so we developed some ideas about occlusion that I want to point out on this that's a little different than most dentists understand. All primitive skulls had an end-on-end bite. They didn't have overbites as modern man has. And tying this information in with what we call neuromuscular dentistry. Neuromuscular dentistry came from Seattle in the early 70s, where they used computerized jaw motion analysis. But those two principles led us into looking at arc of motion. And so the main treatment protocol that we're trying to do these days in our patients is get them so that they open and close on a fair arc, wherever that may be. And in most people, 90 to 95% of patients, they end up with an end-on-end bite. Some cases end up with a class 3, with the lower chin too far forward, or more lower jaw more forward than the uppers. But for chronic pain patients and trying to treat medical complaints, you got to get them on that arc of opening. And so it's a functional motion that dictates where the teeth need to go, as opposed to general dentistry, which is looking at teeth to determine where the jaw should be. So we're looking at jaw motion to ascertain the bite. Here's some other. This is a 3-year-old Siberian girl. Right? Again, we have end-on-end bites, no overbites. The work, I don't know, probably a lot of you are familiar with Weston Price and his works, right? And this gets into a lot of that. I think that a lot of what we're doing, a lot of how we've gotten here is a prolonged, compromised diets over many generations. But the face is our focus of health. Anytime you look at somebody, you always look at their face. Your face is your biggest clue. And this importance of the face has been recognized by a number of other medical models, the acupuncturists, the osteopaths, the chiropractors. The trigeminal nerve, which we'll show you some pictures in a minute, mixes in a brainstem with C1 to C3. So actually your jaw nerve and your upper cervical are the same nerve going in different directions. And chiropractors have realized the importance of the upper cervical for a long time, and this is basically the same thing, saying the same thing that they found. The trigeminal has 100 times more dense pain fibers than any other nerve in your body, and that leads it into the predominant sensory input into the brain, and the brain has to work on sensory input. This is your trigeminal nerve. This is the brain stem. This goes down to about the level of C3 to C5 on individuals. It comes up into the ganglion, comes out 3 branches. One branch comes out right over your eye, and a little notch in your eye. One comes out in a notch below your eye, and the lower division here goes down inside your jaw. And these are the different distributions of that nerve. The only pain fibers in the front 2/3 of your dura, the skin around your brain, there's no pain fibers actually in the brain, come from the trigeminal. So one branch is coming out right here, one branch is coming out right here, and the third one is coming down inside the jaw. The pain fibers are a major part of the trigeminal system, and what makes it unique from all other nerves is its extreme high density of pain fibers. Your C fibers, all C fibers transmit their signal to the brain via a neurotransmitter called substance P, P for pain. And substance P is not a real neurotransmitter, it's a neuropeptide. And neuropeptides linger in the body and have endocrine properties on the body. Okay? So the substance P levels is a major influence on systemic dysfunction. Again, C1, C3, vagus, glossopharyngeal mixed together, right? Get a heart attack, you get jaw pain. When your trigeminal's off, you can get sore throats all the time. Another major part, most people doing this kind of work, they tend to focus on the TMJ. And this is your TMJ, it's your jaw joint that hinges immediately in front of your ear. And you can get all kinds of ear symptoms and facial pain. And this is your temporalis, your primary jaw posture muscle, right? This is the big fan muscle, predominant. This muscle pulls your jaw up and back. It's the one that's the primary pathology in TMJ problems is that your jaw is back too far. This space is compressed in this area. This muscle is working too hard. People get headaches in the temporal muscles all the time, right, side of their head. This muscle, give you some interaction. This muscle is a predominant influence on gallbladder function, right? Chinese medicine, gallbladder meridian starts here, crisscrosses back and forth through that temporalis a couple times. So when you're chewing, that the function of that muscle tells your gallbladder to get ready. Here comes some food. You got to dump the bile in there. But in TMJ, this is overactive. You get a lot of gallbladder removals with TMJ problems. So dentistry has historically looked at teeth to figure out where the jaw needs to be, whether you have a good bite. They just look and see if your teeth are indexed. But what's important in neuromuscular dentistry, they figured out you got to make the muscles happy too. And so teeth aren't the only thing you have to look at to determine a good bite. You have to integrate muscle information. And muscle, the teeth are part of your skeletal system, and you have to have a musculoskeletal balance system. And that's what neuromuscular dentistry looked at. We'll show you a little bit of instrumentation on that later on. The biomechanical principles is that opening and closing on a fair arc. Dentistry doesn't know about that. That's a little bit in neuromuscular dentistry too. They got into that. They graph that with their computerized jaw tracking equipment.
What's a fair arc?
If somebody has a retruded bite, when they go to open, their jaw drifts forward on them before it swings open. And as they close, they'll close forward, and then they go into a loop pattern to get their jaw back up into their skull again. And you want that to be a fair arc. Your TMJ is the only joint in your body that can translate. And since it can translate, dentistry thinks it's okay for it to translate, but it's not. This joint needs to be like every other joint and do a primary hinge motion rather than a translation motion.
A simple arc.
Simple arc, exactly. It does translate anyway, but you want to get that translation to a minimal.
Doesn't the translation grind up the food with the molars?
No, chewing motion is a side elliptical motion. If you're chewing on your right, it goes in elliptical this way, and on your left, it goes in elliptical this way. But this way, we're looking at just an open and closing straight pattern. So when you have a bad bite, the trigeminal becomes hyperactive, hypertonic. Get rid of this one. And so as the trigeminal tonicity goes up, you start getting brain processes disturbed, homeostasis, endocrine, autonomic, cognitive, motor. We're going to look at this quite a bit more later. Influence of associated nerves, autonomic, postural tone. There's some other very special aspects to the trigeminal system, and probably the most important has to do with what they call proprioception. And proprioceptors in your jaw muscles are the sensors that tell the brain where your jaw is in space. And that's what keeps you from biting your tongue and biting your lip, and coordinates everything for you. The proprioceptors of the trigeminal are the only primary sensory cell bodies in the brain. And they have a major influence on a lot of things, and one of them is postural tone. They control the Golgi tendon apparatus in all your muscles, or they modulate it, they affect it substantially. And so it sets the tension in your muscles. And when your bite's off and your brain knows it, then your postural tone changes. In laboratory animals, when they grind the teeth shorter on one side, the crossover in the brain causes the entire opposite side of the body to increase muscle tone, and all the animals develop severe scoliosis. As the substance P levels start going off, it starts affecting all the other neurotransmitters also. So we're going to quickly run through the trigeminal system and give you a quick neurology course here. We're going to cover all these different areas in more expanded breadth. We're going to talk about the sensory zone, the motor. The motor has both sensory and motor parts to it. All your jaw motion muscles would come through your third branch. So sensory to your head, it goes to your skin of your head, teeth, gums, eyes, ears, nose, sinus. And so this gets into a number of pathological consequences when your bite's bad and the tonicity goes up within the trigeminal system. So you start seeing a lot of different symptoms that aren't normally thought of being attributed to bad bites. You can see a lot of skin disorders, eczema. Most skin disorders on the whole body are related to substance P levels. Substance P is known to be associated with a lot of most skin disorders in the body. So if your bite goes off, substance P levels go up, you get systemic skin disorders. Periodontal disease, most dentists look somewhat at bites and trying to figure out periodontal disease, but they're only looking to see if the teeth match and not whether or not the jaw's in alignment. Eye diseases. This is a very unexplored area, I believe. There's basic brain research showing that overstimulation of the trigeminal will cause the skin on the surface of the eyeball to grow scaly. And so you get a dry eye feeling when in fact you have adequate tears. I believe that they'll eventually find that glaucoma, macular degeneration, and a number of other eye diseases are also going to be related because the only sensory to that eyeball is from the trigeminal. Hearing loss, we'll go into that a little bit more in a bit. Chronic sinus infections, autonomics to the sinuses travel with the trigeminal. Trigeminal has a predominant influence on sympathetic, parasympathetic tonicity through a number of different pathways. Headaches, there have been many studies showing that fixing the bite is 85% effective on headaches, regardless of the type of headaches. Current understanding of headaches is that there's no clear distinction between headaches anymore. Some people get a little bit more one type or the other, more symptoms than one than the other. The motor part, these are your muscles of mastication. This is your tensor veli palatini, which is a little muscle that opens and closes your eustachian tube. Tensor tympani is a little muscle in your ear that dampens noises. When the tonicity is elevated in the trigeminal, you're going to get chronic ear infections. You're going to get depressed hearing, tinnitus. Okay. There's been a couple studies done on 3 to 5-year-olds with chronic ear infections, and when they went in and glued plastic on the baby teeth and built the baby teeth up higher to decompress that jaw and lengthen those muscles. In both studies, they were about 90% successful at stopping all future ear infections. brain modulation. This gets into that ADD, ADHD that somebody had some questions on earlier. The reticulars, the triune brain, everybody heard about the triune brain. There's 3 parts. If you look at the brain very simplistically, there's a brain stem, your limbic brain, and your neocortex. This is your reptilian brain. This is what keeps the brain alert. The trigeminal is a predominant influence in that region due to its massive sensory input. That's why when you slap somebody in the face to wake them up, they come to attention quicker than any other way. There's what they call the trigeminal vascular complex. If you look in I think when I looked there was 1,200 articles on the National Library of Medicine regarding the trigeminal vascular system. It's pretty much all regarding headaches though. And very few of them explore, it all has to do with migraines, and very few of them are exploring, like an ADD, ADHD, the PET scans and SPECT scans, that they're looking at blood flow and ADD problems is going to be heavily trigeminal modulated. And there's not much people exploring that, but there does appear to be, you can modulate it through the trigeminal. Again, back to our substance P levels. This gets into your reticular problems. This is your trigeminal vascular system. This gets into your vascular system. Fibromyalgia, you get, that's also known to have a limbic dysfunction. The limbic core of your brain is dysfunction, fibromyalgia, and chronic fatigue. We're going to go into this quite a bit later. The cells which form your mesencephalic nucleus are called neural crest cells. And neural crest cells form a number of other parts in your body. They form all the cranial nerves, all your sympathetic, parasympathetic nerves. It forms the enteric plexus, which goes to your gut. So that's why I think you find this connection here with jaw dysfunction. This is also associated with elevated substance P levels. As substance P goes up in the body, it hypersensitizes all sensory neurons. Okay? Substance P modulates the stress response. It mediates the inflammatory response in the body. So it's something that tends to heighten everything in the body as the substance P levels go up. The way the trigeminal feeds into the brain, there's a descending opiate pathway in the spinal cord that modulates the ascending spinal signal. That's where opiate drugs work. Those are second-order trigeminal neurons, right? That's why biting the bullet works. When you change the bite on people, they don't feel as much pain in their arms and legs. Right? When the bite's off and that trigeminal tonicity goes up, you start getting a lot of peripheral neuropathies. We'll cover that a little bit later on the smell. The hearing, we talked about that a little bit. Taste, see the alteration of taste is with appliances and stuff a lot. This, you get into chronic neck aches. Typically with bad bites, you have a cervical instability problems. When the bite's off, C1 won't hold. It's the same nerve. It's the same. There's both neurological and biomechanical interactions. As you open the bite up, bring the jaw forward, and throws the head back, restores cervical curvature. Limbic modulation. So we talked about the reticular activating system. Now we're into the second part of the brain, your mammalian brain. Okay, the trigeminal has a major influence on limbic function, and hence it has a major influence on the neuroimmune complex. Modulates emotions. There's legions of literature on mood disorders and TMJ problems. And it's depression and TMJ, there's just legions of literature linking those up. This one, I think, is a lot less understood. We see this very frequently clinically, though. There's a lot of research. One of the handouts is on a book called The Dental Physician. He talked in there about lots of cases of repetitive pneumonia that went away when he fixed the bites. He had lots of cases of mononucleosis where white blood cell counts normalized routinely within 24 hours of building the bites up. So the major, he had some private research that he'd done showing he could alter the shape of red blood cells within about a week's period of time with splint therapy. It's good to oxygen transport, a number of other things. So we see these things tending to go away to stabilize. You get both into hypo and hyper problems. See a lot of kids that are sick every week, every month. You get the bites stabilized on them, they tend to stabilize a lot. So this is that mesencephalic nucleus, where those primary cell bodies, the jaw alignment sensors from the jaw go to. Modulates Golgi tendon apparatus. That's where you get the systemic muscle tension. I think a lot of back pain is related to this. And if you got the upper cervical out, lower back's not going to be stable. Tension's going to increase in the lower spine. There's also apparently a low thyroid is a chronic finding with jaw dysfunction. I also think there's a calcium utilization disturbance with jaw dysfunction. We've had a number of cases. I had one case that had 40 broken bones by age 18. When we fixed his bite, we followed him for 5 years. He had 2 major falls and never had another broken bone. They told him he had a genetic disorder. And so we see that the calcium connection also on the periodontal disease and through a number of other examples. I've had 5 cases of non-union ankles that were never healed until we fixed the jaws. Like people have been, they tried stimulators, bone grafts, everything. In laboratory animals, when you throw the bites off, it throws their mineral levels go wacko. There's basic brain research showing that the trigeminal has the ability to modulate nutrient levels in the blood, all the way from your proteins and fats, sugars. Hypoglycemic symptoms are a common symptom with jaw dysfunction.
Sir, is that because they can't ingest food or because of some internal biochemical mechanism?
It'd be internal biochemical and internal neurological influences. Yeah, a lot of these cases, they're not aware that they have a bad bite. They're not. A lot of these are covert symptoms. There's no obvious jaw dysfunction, obvious pain complaints, or tooth difficulties that they're having. As these bites retrude, it's a very covert dysfunction that creeps upon us that's often not recognized. So again, this is where we think the primary pathology is in the bad bite, is in those alignment sensors. So, this is, I think some of you had the opportunity to hear Robson speak and what he was showing on those cases where he's treating primarily sleep apnea or airway obstruction cases. And as he brought the jaw forward, he's shown dramatic increases in autonomic tone. In all cases, 99% of cases, TMJ is from the jaw being back. When it's really far back is when you get into those sleep disorder cases. And those is what he would be looking at with some of the more extreme cases of jaw dysfunction. Most cases that I treat, the jaw is retruded 3 millimeters. That's where they start getting substantial symptoms. Some cases you see where they're all 5 and 6 millimeters. Some cases get into symptoms at 1 and 2 millimeters, right? Around the 16th of an inch retrusion on them. See a lot of dizziness complaints, gait. When I was treating myself, I had just a very infinitesimal piece break off my appliances, and immediately one leg wouldn't swing around on me, and it lasted for 24 hours. I couldn't perceive that my bite had changed at all, but immediately my gait, my leg wouldn't swing. I'm doing a lot of dizziness symptoms. That gets into vascular blood flow and vestibular system also. Chemoreceptors, I think this is a very big overlooked area. Stanford, 1972, they showed that the trigeminal has chemoreceptors. Okay? The olfactor is discriminatory. You know, oh yeah, that's skunk, right? But when you smell something and it makes you sick, you start feeling nauseous. That's trigeminal. Okay? And this trigeminal, there's a number of things that can cause that trigeminal overactivity, cavitations, bad teeth, root canals, other things like that. But most of these are going to be covert jaw dysfunction. Okay? This gets into asthma, allergies, multiple chemical sensitivity. The Japanese have done some research on asthma. They claim an 80% success rate treating asthma with dental appliances. Get those bites lined up and the sensitivity of the body drops off. One of the handouts we had was there's been now seen about 4 or 5 studies show that with TMJ and jaw problems, you just get to see a lot of chronic illness. There's the protein levels in blood, immune function, rheumatoid arthritis, MS. There's lots of literature on this and TMJ. They're trying to show that TMJ is a rheumatoid symptom, but I think it's the other way around. I think that as that TMJ goes off, your substance P levels go up. You get the pro-inflammatory conditions set up in the body. Nutrient levels start going off. Your immune system starts going wacko. You start getting into the rheumatoid arthritic. And I think MS, in the monkey and dog studies, when they grind the teeth short on one side, they become severely weak on the opposite side of the body. They start dragging their legs. The monkeys quit swinging by their arms. Right? I think that's a lot of what you're seeing in MS, that weakness that they see, the neuropathies. Some of my MS cases, I think we're looking at a long-term chronic vascular insufficiency leading to a lot of their symptoms. There's been many studies now done on athletes, and when they line the bites up on these athletes, they have an immediate increase in circulation to their arms and legs. They're stronger, right? You can muscle test them, they're immediately stronger when you get that bite lined up on them. And that, again, I think you're seeing a lot of that in the neuropathies in MS, the numbness, tingling, weakness. We've been looking at this generalized hypersensitivity syndrome pretty close for the last probably 3 to 5 years. I can't remember exactly when I started focusing on it. But with long-term trigeminal hypertonicity, elevated substance P levels, you end up with a central hypersensitivity syndrome. There's now been, I've seen about 4 or 5 studies done on this. I need to write this up. I've never seen a decent article on this relating to fibromyalgia. Okay. There's a lot of, I've seen a number of people poking holes at it, but nobody that I've seen that's looked at it knows how to reverse it. And that gets into lining that bite up extremely precisely for a prolonged period of time, and you get the neuroplasticity effects coming in, and the body starts calming down. These patients become hypersensitive to any and all sensory input. Okay? Hypochondriac. Okay? Illness is not what happens to you. Illness is how you react to what happens to you. And these people overreact to everything, all sensory input, particularly anything stimulating the trigeminal, right? They get hit on the head, they get dental work done, they have nose surgery, they have a minor whiplash injury, right? They go off the deep end. A little more input to that trigeminal cervical axis, and then they end up with chronic illness. They're already chronically ill, but they'll end up, puts them into fibromyalgia.
Could you repeat that where you said illness is not what happens?
Illness is not what happens to you. Illness is how you react to what happens to you. And in hypersensitive people, they overreact all the time. Their bodies go out of balance. Their homeostasis is disturbed. They don't have their sensory neurons put in too much sensory input. Substance P levels are too high on them. Their neurotransmitter levels are all altered on them. So you got to figure out how to calm these people down. And a big thing on calming these people down is getting that trigeminal sensory, that massive sensory input from the trigeminal brought down on them, and then the whole brain can start calming down on them. You lose that. You got to get rid of that central hypersensitivity on them. This is a big part of chronic illness. This is what they've shown in those studies linking TMJ and chronic illness. Right? The problem with dentistry is that dentistry doesn't have a good theory of occlusion. They're still looking just at teeth. They're not taking enough information into consideration. The instrumentation that they're using on a hypersensitive person, dentistry does not have enough precision in their treatment protocol to reverse these cases. We're going to go over this a little bit more here in a minute too. Dentists think they're working just on teeth, right? And when things start going crazy, they still think just teeth. Right? These hypersensitive people, anesthetic doesn't work. They just keep giving them shots. Right? They don't understand this, right? So when you come up with something crazy, you know, one time I was in a chair and they used a slow speed drill on me with real heavy vibration, using it real slow. I momentarily went unconscious. Okay? I was out for about 3 seconds. Right? I could feel myself go down and come back again. Right? You know, how did that vibration cause that? Right? You know, how does a person go unconscious when they get hit with a box, when a boxer hits them? What's that mechanism? Why do they lose a blood supply to the brain? Right? Too strong of trigeminal sensory input. We just have some major problems in our profession in trying to understand this problem and to integrate our therapy in with the medical community on trying to treat a lot of these cases. We're going to show you some cases here just to give you a little bit of idea of how we treat these cases and how we maintain our precision. This is somebody who had bicuspids. Here's a molar of bicuspid. There should be 2 bicuspids in here. Orthodontist pulled 4 teeth on this person and messed up the bite real bad. So this person is kind of what we call class 3, right? These front teeth are ahead of the upper teeth. And you can see our little appliances that we use in here. These appliances that we use, these little metal frameworks, were patented in 1905 by a dentist out of New Orleans called Crozats. Most people using Crozats don't use plastic pads on them. They don't understand the dimensional control that they need. They're just trying to use these appliances primarily to grow jaws wider. We're treating these jaws 3-dimensionally. We're going to grow the back teeth taller too. And we're going to cover most of the teeth. Back teeth aren't going to be covered. The back teeth will start growing in longer. This person is postured with their jaw forward. Right? There's a lot of space when you take these appliances out. We've got these back teeth are going to grow first. We're going to open up this missing tooth spot here and here as much as necessary to get that jaw out on a fair arc. These are what these little appliances look like when you take them out of the mouth. They're the least bulky thing that we've been able to come up with that'll do the trick. And you got to get this bulk out there to maintain function so people can still talk and have a life. Most things that dentists are using are big, bulky, full splints, and they don't have any ability to move things around. These are a complete orthodontic system built into the splints. This is a little bit fuzzy here. This is the front teeth here. This is another major part of our armamentarium. There's little plastic bumps that we put on the back of these front teeth. And when they bite down, they hit these, and it's going to let all the back teeth grow in longer. And we're using these appliances to coordinate the back teeth as they're growing in. These little wires start in the back, move the last tooth out, add another little wire coming forward, move the next tooth out, and start in the back and come forward. 90% of your symptoms come from how you hit on the very last tooth. It's the most retruded tooth is the most important. In fibromyalgia cases, how they touch on that back tooth has to be unbelievably precise, or all their symptoms come back on. Dentistry doesn't know this. Most dentists use carbon paper to check how you bite. Doesn't work on hypersensitive cases. What we use is this is a polysiloxane material. It's a little blue, looks like a caulk gun that we squirted in their mouth. This shows, we're looking up at a bottom tooth here, but I can turn it over and look at the top side of it also. It shows how these teeth come together. And teeth need to line up like gears. So your upper teeth hang a half a tooth out over your bottom teeth. The inside peak of your upper tooth has to hit the very center of your bottom, and the outside peak has to hit the very center of your top. Dentists have forgotten this. They learned it in school, but they've forgotten it, and they get sloppy. So when you look at this one here, This is the inside valley of this, and this is the outside ridge. It's a little bit, I can't quite read this one here. But we're reading these things and making sure that the peak from the upper tooth as it comes through is at the appropriate place on this bottom one. Actually, this is I think we're looking up at a bottom tooth. And there's an upper tooth coming down into it from the other side. And this peak should actually be over here on this valley that runs up and down this tooth. Right? So this tooth's got to go out. That's about 1.5 millimeters wider to get that precisely coordinated. And so we'll be able to measure on these things in the neighborhood of 10,000ths of an inch. This is like plastic gauge that they use to put motors together, any of your mechanics. The neuromuscular part, we have little electrical stimulators that we hook onto the faces. And this slams their jaws shut, kind of. It closes them without their brain working, so it allows us to generate a bite and takes all the torque out of the bite. When people close on their own, they close too hard, and they end up closing. They can pull the jaw one way, and it looks even, when in fact their muscles are having to accommodate all the time to get their teeth into that position. This guy here, chiropractor, went to the dentist. They did full mouth reconstruction on him, all the upper teeth one day, came back the next day and had all the bottom teeth done. Ended up with a heart rate of 160 and was hospitalized for a week. He lost his practice. It took him a year to recover. Long-term TMJ case. They had splints in on him when they reconstructed the mouth. They didn't follow through on the splints. They put temporaries in there that didn't support his jaw any longer. Right? His autonomic nervous system went off the deep end. Became severely ill. Part of our other appliances that we use is like our nighttime appliance we'll use. These appliances keep the jaw from falling back at nighttime. This is like a sleep apnea appliance, or we use them in TMJ cases too a lot of times. A lot of times we grind the plastic out in the back. It lets the back teeth erupt some at the same time. This is a German appliance. Developed this 1930s and 40s in Germany. Been around a long time. In conclusion, jaw dysfunction, cranial-mandibular dysfunction is underdiagnosed by all health professionals. It's misunderstood by a great percentage of the dental profession and hence treated ineffectively. Jaw orthopedic therapy is an effective therapy for a multitude of disorders. I think that the extent to which the applications that this has is still very limited. Those proprioceptors from the brain also form a number of other, they form the anterior plexus. They form all the melanocytes in your body. That means that most likely vitiligo, where they get white spots on their skin, is going to be a bite problem, right? There's a lot of other implications like that. Looking at the neurology of where this could take you, and that you'd probably have success treating a number of disorders. I think that's it in conclusion. Question?
I can sort of fill in between the lines and try to guess what the actual treatment plan is, but I'd like you to tell us what...
So treatment is 2 phases. The first phase is get the body calmed down, get the jaw lined up. Second phase is
what does that mean, get the jaw lined up?
Get it on a fair arc.
How do you do that?
With these little appliances.
So you make an appliance and then you go through like...
Those appliances are diagnostic. They're there to find out where it is that the jaw wants to be. You've got to get that fair arc, get that jaw working right. Another primary principle that's highly effective or highly useful is that people should bite and talk on the same trajectory. Most people bite retrudedly and their jaw thrusts forward on them when they talk. And we've got to get all that thrust out of there. We've got to get that. We've got to get this thing like make them look like they're ventriloquists, so they can talk without moving their jaw. We've got to get this to a minimal range of motion, minimal function, and minimal motion and function. We want them so they bite, talk, swallow, rest, everything all on the same trajectory without a lot of motion going on.
And that's just with the first appliance that you make?
Those appliances are used for both phases. So you use it initially in first phase to line the jaw up, but once you get the jaw lined up, you keep them lined up with that appliance and then start using that appliance by cutting the plastic off in the back and adding little wires to it to move teeth, to get the teeth to support the jaw on a permanent basis in that position.
So you make an appliance and then you make adjustments to it over time until eventually the teeth grow differently and the bite is different at the end?
Yes.
Okay. How long does this take?
Varies on people, some cases 5 years.
And how much does it cost?
Varies, again, on cost. Most, if we're doing it on a young kid for orthodontic purposes without a lot of medical complaints, it normally runs in the neighborhood probably about $2,500–3,500. If you're doing it on an adult, somebody's had teeth severely hypersensitive, you could run up 5–7 years and make costs as much as $6,000–8,000. Question?
What kind of metal do you use, and do you do any kind of biological testing to see if people are allergic to the plastic?
We do biological testing on the hypersensitive cases. We have basically 3 types of metal. We have a high-grade gold, it's about an 18-karat gold metal that we use. All of them are alloyed. We have a stainless steel that we use out of Italy, and then we have a nickel-free that we also use.
I can get a ringing in my ears depending on how I bite. I move my head forward and back. What's going on?
Oh, what's your question?
How does the bite affect tinnitus?
There's a ligament actually that goes from your jaw joint into your middle ear, and so you can impact what you're hearing, or what you're hearing right through your middle ear. All those middle ear bones are developmentally from the jawbone.
Sometimes people that are overweight develop sleep apnea, and they say it's too much excess tissue back there. Is it excess tissue, or is it inflammation? And either one of those cause the jaw to go out of alignment?
What the research shows is that 85% of the time sleep apnea, snoring, is from the tongue blocking the back of the throat. Okay, so when you bring that jaw forward and bring the tongue with it, it's highly effective at stopping moderate, mild, moderate, and some of up into severe cases of sleep apnea, snoring. Question?
Are there any people that are normal?
Almost none. Yeah, probably less. Almost none. Probably 3% or less, I would think. Yeah, and what those that are functionally ideal would be considered dentally abnormal by dentists. If they end up with that jaw that far forward, dentists would think that was excessively protruding lower jaw, and would want to treat it. Yeah. Question?
Is there pain with the use of the appliances, like with regular dentistry appliances? And is there anything associated with the trigeminal nerve and things like tonsil surgery or that kind of thing?
The first question, when you're making these appliances, it's a process and not a procedure. So the first time you put those appliances in there, you don't always get them precise, and then you can cause short-term problems on them, but that's your clue that you haven't got it right yet, and you got to keep working on it. Jaw alignment, due to its impact on the sympathetic nervous system, the autonomic nervous system, has a major influence on heavy metal accumulation. So bad bites are a major part of this heavy metal toxicity problem, and that gets into muscle tightness and the accumulation things. It's also a major contributor on the tonsil enlargement. Issue of congestion, lymph congestion. As that systemic tonicity goes up in the body, you'd see more lymph congestion. As those mineral levels and homeostatic levels of nutrients in your blood start going off, you're going to see more lymph congestion problems.
So surgery to that area could also impact the nerve as well?
Correct. Now back on the pain side too, kids that are going through ortho and they're having a lot of pain from their ortho, they got the bite wrong, right? This trigeminal system is really peaking, and it makes the little things cause a lot of pain on it.
2 questions. One, what about posture therapies like Alexander technique that puts your head here, moves your as a technique for dealing with this? And then, unrelated, how does it affect sinus?
So the bite, your jaw is part of your postural chain. So the bite has a major influence on posture. There's a number of books out there on TMJ and posture. Gelb, one of the guys out of New York, wrote a really good book on that. So pretty much all exclusive TMJ and posture connection. What was the last question? Sinus. So all the autonomics to your sinus travel with the trigeminal, and you see chronic sinusitis with jaw dysfunction all the time. I think the study that I handed out here on chronic illness showed that the TMJ people went to the ENT 10 times more often than normal to the population at large.
Yeah, is there any way to determine the likelihood that this kind of process will be helpful diagnostically before having to go through 3 or 5 years of actual treatment?
Joint films and motion analysis and bite things give you a good indication of what you can expect. And also looking at taking a medical history, it's a little bit like doing a homeopathic history. If you take a real thorough history, you'll get a pretty good insight as to what symptoms they're having and whether you're going to be successful at those. But you're going to generally find anybody that's chronically ill, that there's going to be this going to be a part of the component, most likely.
Well,
If
if
you can-
everybody, if 97% of the population has this, then the chances of a chronically ill person having this is really high.
Really, really high. Yeah. Question?
Is the converse true? If one has none of those symptoms, does that mean the jaw's probably okay? Or?
Not necessarily. Most people are still highly accommodative, and it's just that this system hasn't hypersensitized on them. My history, as I was growing up, my bite was off. I clenched all my life, all night. I had severe wear on my teeth. My sternocleidomastoid stayed tender. I had a little bit of hypersensitivities. I couldn't stand long sleeve shirts. Had bedwetting. It's probably related. But pretty much nothing else. I didn't have much other symptoms. As I got older, I got more tinnitus.
You still have tinnitus?
No, mine's pretty much exclusive, totally gone. If I really stop and listen. It used to bother me at night though when I went to bed, and it's now probably 80% gone.
Sinus is an infection of bacterial or fungal. How does a physical change affect the bacterial infection?
It's going to change the environment there. You're going to change both the immune. It's like ear infection. You can only get an ear infection if you get a drop in immune function. But that's you got the immune component going in there. The neurological input of the autonomics is going to change the quantity, quality, and viscosity of mucus secretions in your sinus. It's going to change the environment, allowing the bacteria to grow.
For your specific kind of training to do this, did you get that here in the States, or did you get that in Europe, and where in Europe?
I did all my training here in the States. This isn't taught anywhere in dental schools in this country, so it's a lot put together. And so most people treating these problems have a very eclectic background, very varied background. So there's really no. Most of this neurology that I'm giving you here today came from my insight and experience treating a lot of epileptics. I had to go figure out a way this worked on seizure cases. And most people don't know this neurology that we're sharing with you today. It's not in the textbooks anywhere.
Are you practicing this at all in Europe, or is this more of a U.S. thing?
I'd say this would be more of a U.S. thing. There's so the primary TMJ guy came out. There's a guy in Albuquerque in the 1950s that did it heavily. There's one excerpt from the book called The Dental Physician. That guy did it in the Midwest. There's another guy in the Midwest was using really tall splints treating postural problems back in the 60s, 50s, and 60s. And so there's been some main key guys, mostly in the States that I'm aware of. I'm not aware of much coming out of Europe.
As we grew up, the classic was that all your children had to have their wisdom teeth extracted. What is your reading on that?
You'd want to keep wisdom teeth if at all possible, but we've degenerated to the point that more than 2/3 of us or better don't have room enough to keep them. But dentists don't like to work that far back in the mouth, so they tend to recommend they all be pulled, but you'd want to keep them if at all possible. There's a lot of support that far back.
So, can you feel symptom relief right away, or is it gradual over the period of a real life?
Depends on patients. Some people, about half of them are going to get immediate symptom release, and the rest of them is going to take longer. Like on chronic fatigue cases, it's usually going to be a while before they respond. I had one case recently, though, that 2 days later she walked 11 hours around San Francisco. She'd been bedridden before. So you get some immediate cases, but most of those, it's going to take a while for that neuroplasticity effects wear off for them to respond good. I'd like to also have take an opportunity to have my patients that were good enough to come today to stand up and
Will they show us the teeth?
share. Let me introduce yourself there.
Hi, I'm Krista Caulfield. I've been a patient for 5 years. When I first saw Dr. Jennings, I was very, very sick. I was basically losing the ability to sleep. I was down about 4 hours a night, and you can imagine what that does to you. I also had sleep apnea because I'd had braces as a teenager, and they had pushed my lower jaw back, so I ended up with sleep apnea. I was also very chemically sensitive. Just a whiff of rubbing alcohol would make me pass out. I had gone from doctor to doctor to doctor to doctor. They couldn't find anything wrong. All of my lab tests came up normal. The very first night that I wore the splints, I slept for 8 hours like a baby. And that continued for about 2 weeks, and then it slowly wore off. But then I had my splits adjusted again, and I slept again. And basically over about 2 years, I worked my way back very consistently to basically normal. And the first thing Dr. Jennings did was move my lower jaw out until I was hitting my front teeth, and my front teeth had to be moved out. And in that process, it opens up the space of the teeth that were pulled when I was a teenager, when I had braces. And right now we're just finishing tweaking the bite, and it'll be all done. And it's fantastic. I feel better now than I have felt in my entire life.
All right.
My name is Adriana Finney, and I've been with Dr. Jennings, I think, 4 years. Yeah? When he talks about those hypersensitive kinds of people, that was me. I said, whatever metal you use. We laugh. I'm probably one of the more sensitive patients that he has. He had to take all the metal out of the splint. He had to make a special splint for me. He had to get very creative with me. If somebody... Oh, it's there. Anyway, when somebody walked by with me with perfume, I would just go in the bathroom and often throw up. I went into a brand new home just to look at a home once, and within 5 minutes I had to run out because I was violently ill. And my biggest challenge was with wind. I also had chronic fatigue syndrome, and I'm now stronger than I ever was. But on windy days, I literally felt the wind inside my head. So I had to go to bed and put pillows all around my head just to tolerate the pain. And in the last several years, I've noticed that March is a windy time, and it's windy, and I'm up, and I'm okay. I also have a son who's now 8, but he started 4 years ago. He had sleep apnea. He was a lot of ear infections, sinus infections, and his walk, one foot was totally turned towards the other one. And so we were going to go to an orthopedic, and I was talking to Dr. Jennings. He said, bring him in here. And I said, wait a minute, the bite is going to affect the kid's foot? He said, yes. In 3 days, he walked straight. He no longer snores. His mouth is closed when he sleeps, and he hasn't had an ear infection or sinus infection since he started. And this is my dad.
Hi, my name is Hans Philippi. I'm 83 years old. And when I met Dr. Jennings a year and a half ago, I said, well, you cannot fix me probably because it's too far advanced. I have macular degeneration, and I'm blind on one eye, and the other eye is, so my vision is 2400 to 2600 both eyes. I had constant bleeding, and my bleeding did not stop. I had photodynamic therapy 9 times. I had feeder vessel treatment in both eyes twice. I had laser treatment around, low laser treatment around the eye 160 times on one eye, 150 on the other one. And the bleeding did not stop. And all the ophthalmologists I have consulted, they gave me, first of all, I had radiation in one eye, and there the blood came to stop more or less. It did not stop completely. Then on the other eye, I'm blind for...
Turn towards the camera.
Where?
We can see your face. There you go. There you go.
The other eye became, started with in 1st of January 2000. And I was studying what can be done. So the only thing was photodynamic therapy. I went even to Switzerland twice to have it done because it was not allowed in the United States. But the constant bleeding and leaking of the macula, I had wet macular degeneration, continued, and the only thing I can tell you is if somebody has wet macular degeneration, avoid the altitude, number one. Go to acupuncture, a special acupuncture which they do only in Arkansas, not in the head and in the forehead and somewhere, but they do it in the feet. And they put up to 30 needles in your feet, and it takes 2 weeks and you feel better. But whenever I came back from Arkansas, the bleeding got again, they started again. So the vision deteriorated, and then I saw Dr. Jennings and said, let's try this. And he tried it, and I can tell you the bleeding stopped, and the leakage stopped, and my eyes are not wet anymore. And this is happening after about half a year of treatment with him. All the doctors said, well, we don't explain it, probably it wears out, but it doesn't wear out, it gets only worse. So if somebody has macular degeneration, let Dr. Jennings try, and he has a result.
So what's happened as a result with your eyes?
As a result, my vision stabilized. It doesn't get better, but it's stabilized, and I can still see a room here. I can still see a person over there, but you have to stabilize in order not to get completely blind. My mother died when she was 92 and she was blind completely of wet macular degeneration. But this was 20 years ago and they didn't have anything. Now they have some treatments, but nothing is so effective as these 3 points. Don't go to the altitude. Go to acupuncture and see Dr. Jennings, and they can help you. And if you want to see what I have now, okay. This is a thing which I have for 40 years. And Dr. Jennings put a little lining on top of it, and my bite is corrected, and I feel much, much better.
Wow.
Thank you very much.
Where did you go in Arkansas? What town and what place?
That was not a town. Hot Spring Village in Arkansas, Dr. Otti. He's a Danish acupuncturist, and he has a special procedure for macular degeneration. There's another doctor in Denmark, the second he was associated with him, and there's a doctor in, I think in Reno England Village, I don't know, I got just the telephone number. And he has the procedure from the second doctor, and he claims it has the same result. I don't know. I have seen people in Arkansas, and they had even MS, what's it called, multiple sclerosis, and the lady was there for the 3rd time, and she said, okay, lift your foot. She said, I can't. The next day, he treated her, and she said, can you lift your leg? Oops, went up. It was amazing. But there is a combination, and you have to see him. And you have to see him, and he will do some treatment. And at the beginning, I was not very thrilled.
And how did you spell Adi, Dr. Adi in Arkansas?
Adi, O-T-T-I, O-T-T-E. He's an...
and horrible neck pain, horrible headaches, every sensitivity in the world. And I was in chiropractic care for 6 months before I saw Dr. Jennings, and once I got my splints and my C1 and C2 finally held, it took a few months, but I still see a chiropractor, but only once a week or once every other week instead of 3 times a week, and it's more for just upkeep. But I would say my headaches are probably 85% better. Yeah, it's been fabulous for me.
Okay. Even if they can see a compression of the trigeminal nerve?
Yes.
Okay, I'll tell you what, more questions later, informally, be fine. Thank you very much. Thank you.
Phil, there's still 5, we had 5 books back here, we
Okay.
didn't realize we had.
Preview of a meeting coming up next week. I'm going to talk very briefly about the American Aging Association meeting, which was held in St. Petersburg, Florida in early June, and the Alzheimer's Association meeting, which will be held in Philadelphia next week. And among the highlights, I'll be talking a little bit about Alzheimer's disease. I've talked before about cross-linking, and I don't think I'll mention that tonight. The American Aging Association is a membership organization of scientists and interested non-scientists. They held their annual meeting June 4th through 7th in St. Petersburg, Florida. And their next meeting, which they hold in a different city every year, will be in the Bay Area. And this will be, I think, a good opportunity for those of you who are interested in meeting some of the scientists who are doing research into the biology of aging to actually meet some of the people. You can find out information about this organization at their website, americanaging.org. One of the most interesting speakers, in my opinion, was Ashley Bush from Harvard Medical School, who brought us up to date on the work that he and his group have been doing for the last 10 years on a drug which apparently reverses Alzheimer's disease by dissolving the amyloid beta plaques in the brain. They ran public clinical trials in Australia 2 years ago, and they're discussing with the National Institutes of Health and the British Medical Research Council doing follow-on clinical trials. This drug is particularly interesting because it's off-patent, and being off-patent means that once it's approved as a use for Alzheimer's disease, it will be very cheap because there won't be the patent royalties to pay to the drug companies. They found that the effective dose is at least 500 milligrams per day. They're planning to, in the future trials, try a variety of doses to see which dose works the best. It does block vitamin B12 absorption, so all of the patients on the trials are getting extra B12 to make sure that they don't become B12 deficient. The company in Australia, which is sponsored the first trial, now has a slightly modified version which they say works better in their animal testing, and they've patented it. So they're going to do their next trial on their own proprietary drug. It will take longer to get on the market, and it will be more expensive. Maybe it will work better. I'm encouraging them to continue to do that development, and I'm encouraging the government groups to continue to work with the old drug so that we'll have a variety of options for this terrible disease. There's also a group in Israel which has a similar compound that works similarly and seems to be producing similar beneficial results. In each case, the plaques in the brain are getting smaller, and the behavioral aspects of the people's ability to remember and function in society is improving. Plaques are what we call these little globs of protein that are found in the neocortex of Alzheimer's brains. And they're also found in the normal brains of old people. And we now believe that, that these plaques develop in response to a lifetime of oxidative stress. And it's becoming more and more accepted among researchers that antioxidant treatment may be effective in reducing the rate of accumulation of these plaques. This experimental drug actually dissolves the plaques, which trap the metals zinc and copper in the neocortex of the brain. And these metals act as sources of free radicals. So by getting the metals and the plaques out of the brain, we take away a source of damage which has been killing off brain cells. Interestingly enough, very similar mechanisms are implicated in Parkinson's disease. In this case, it's a different structure in the brain, and it's a different metal iron, but a similar thing is happening there. And it appears, according to Julie Anderson at the Buck Institute for Age Research in Novato, up across the Golden Gate Bridge, that Parkinson's patients could be benefited by these same class of drugs.
What animals get Alzheimer's and how can you tell?
Most of the research is done on a research model in mice which don't normally get Alzheimer's disease, but they genetically modified them to get something that is like Alzheimer's. In terms of natural animals getting it, dogs and monkeys do. And there's some very interesting research being done by Carl Kottman at UC Irvine, who is working with dogs, which develop Alzheimer's disease and cognitive impairment in old age. So I think dogs might be a very good model because they get Alzheimer's at about age 14 or 15.
You find out by postmortem.
That's, yeah, but they can also, the Irvine group has developed some intelligence tests for their dogs that are finely tuned enough that they can actually see declines with age. Also at the St. Petersburg meeting were confirmations of earlier results that many of us are already familiar with. Vitamin E is not only an important antioxidant, but it has some anti-inflammatory effects and perhaps some cell signaling effects as well. PBN is another powerful antioxidant which also acts as an anti-inflammatory. In fact, the cross-link breaker ALT-711 not only breaks cross-links, but it also acts as an antioxidant and an anti-inflammatory. It's becoming more and more apparent that oxidative stress triggers inflammation, and inflammation kills off brain cells. Yeah. Okay, I'll wrap up. These are just some of the factors involved in aging, which was covered at the meeting. Next week in Philadelphia will be the biannual meeting. They meet every 2 years of the Alzheimer's Association. More information available at www.alz.org. And I'll turn it over to the next speaker now. Thank you.
He's a young guy.
He's 110 years old, ladies and gentlemen. How's he doing? Unbelievable. How does he do it?
Methyl magic. Methyl magic. We should have one of these things that, holds it.
That's a good idea.
Does everybody know what a methyl group is?
Of course.
Okay, well, we're going to find out.
No.
The first slide is going to tell us. I got one of these things. It works. Here it is. CH3, which is a carbon and 3 hydrogens, is a methyl group. And this simple structure is amazingly versatile in the human body as far as your health. And you can see here that the methylation is an essential metabolic process that takes place in all cells. Adequate methylation is determined by homocysteine levels in the blood. Below 7 micromoles per liter is required to attain a state of maximum physical and mental health. Most of the people that I've talked to don't even know what homocysteine is. So, and when I was at Kaiser, I said I wanted a homocysteine test to find out what level it was. And the doctor said, oh, you don't have heart disease, we don't do that test. So maybe some of you are in that category. Anyway, homocysteine is very important, and it will determine the degree of methylation that you have. And the risk of heart disease varies with the square of the homocysteine level. So if you have a homocysteine level of 7, that squared is 49. If it goes to 10, from 7 to 10, that squared is 100. So your risk is double in going from 7 to 10. Got that one? Okay. So, and I have a cousin who has heart disease. Her homocysteine's 18. You know, and it goes to all levels. If you have a disease called homocystinuria, it goes up to 1,000. And at that point, 8-year-olds die of heart disease. So it's a very important measure of your degree of methylation. And by the time we're done today, I'm going to show you how to lower it to 7 or lower, provided you do it. Okay. Let's go to the next one. Oh, before we do that, I want to mention one more thing. You're going to go to the doctor and get it, and the normal range is 10 to 15. And I would like to say there is no safe normal range, because the biggest disease, biggest cause of death in the United States from disease is heart disease. And the people who are getting the homocysteine tests are the ones with heart disease, and the normal range is 10 to 15. Figure it out for yourself.
What unit?
It's in micromoles per liter. It says here, micromoles per liter. Okay, next one, please. Now, the importance of the methylation reactions in the body. Let's go over them. The production of acetylcholine is the main neurotransmitter in the cholinergic nervous system. And choline happens to be trimethyl amino ethanol. It takes 3 methyl groups to make choline. And the body has normally many acetyl groups, so it can make acetylcholine. The next one is the production of epinephrine, which is adrenaline, from norepinephrine. Norepinephrine requires methylation to make epinephrine. And that's the main neurotransmitter in the adrenergic nervous system. So the next one is that a reduction of excess neurotransmitters by monoamine oxidase, MAO, and catechol oxygen methyltransferase, it's called COMT, C-O-M-T, methyltransferase, to restore balance. In other words, when you get too many neurotransmitters, the body has to get rid of them. Say you've gone through an excitement of some kind, and your neurotransmitters are up, dopamine and adrenaline. And after the incident is over, the body has to dispose of the excess. The excess requires monoamine oxidase and catechol oxygen methyl transferase to get rid of the excess by conversion in the liver. The same thing is true of excess steroid hormones. By using COMT detoxification. For example, excess estradiol is highly toxic in men and women. And COMT is it's called catechol oxygen methyl transferase. Attaches a methyl group to the steroid hormone, and the body disposes of it that way in a detoxification system. So methylation then is, let's go back over this. It's necessary for acetylcholine, it's necessary for adrenaline, and it's necessary to get rid of the excess neurotransmitters and the excess steroid hormones. Otherwise, you're going to be poisoned. Let's go to the next one. We're there. Methylation is related to DNA. Methylation is required to repair DNA. How does DNA get damaged?
It's hit by free
what?
radicals. Free radicals hit it.
Free radicals, okay, that's radiation, eating irradiated meat when that comes. It may be here, I don't know. Anyway, depleted DNA methylation activity is a cause of aging. And lack of methylation of DNA causes DNA chain breaks and mutations that cause cancer. So methylation is a very key to repair your DNA. DNA methylation is essential for normal embryonic development. In other words, having a baby, it's necessary that the mother take in DNA, take in methylation nutrients so that the baby has the methylation. We've got more methylation coming next. Let's look at energy. Methylation of guanidinoacetic acid, forget that one, forms creatine. Well, you know creatine. Jimmy had, how many pounds of creatine were you taking? Where are you?
I told you the story where Swanson had a 2-for-1 thing on everything but creatine, but when I made the order for a bunch of stuff, they gave me 3-for-2 and creatine.
How many?
9 pounds.
9 pounds you were taking. Okay. But creatine is very important. Creatine, adding a phosphoric acid group to the guanidinoacetic acid forms creatine. No, I'm sorry, methylation does. Then subsequent phosphorylation creates creatine phosphate, which is a molecule that stores energy. So when you have creatine phosphate, you have stored energy that is available when you want to sock somebody in the jaw, takes that energy, and then it turns into creatine. It goes from creatine to creatine phosphate. Creatine phosphate is used when you use your energy, and then it's recycled. Body recycles it back to creatine phosphate, and you're ready to go again. So it's Steve called it a battery. It's like a battery. Now, here's a one you may not be aware of. Methylation of a serotonin compound forms melatonin. So that when you have, if you're taking 5-HTP, for example, and calming you down, it requires methylation to make it into melatonin. Then you go to sleep. Because you see here, melatonin is actually acetyl-methoxyserotonin. Fat burning. Carnitine is a trimethyl amino acid that is used to transport fats for fuel use. So, if you are on the zone diet, you're trying to lose fat, you need creatine to transport the fat from the fat cells to be burned. Not creatine, carnitine. I'm getting mixed up. Carnitine, and carnitine is trimethyl amino acid. So it has 3 methyl groups. I have some other notes I'll tell you about. In Alzheimer's disease, that John has been talking about, creatine phosphate used for energy is highly inhibited, 95%. In other words, the Alzheimer's person has a 95% reduction in the energy used in terms of creatine phosphate. And it's that inhibition of energy use is highly dependent on mercury. That's what mercury does. It poisons that system. So that let's go back to the brain a second. The brain consumes how much energy of the body? Ken?
50%. 50%?
20%. Okay, 20, 25, it's high. But let's put that in perspective. The brain only weighs 3 pounds. That means the other 160 pounds is consuming 80%. And if you put that on a weight basis, the brain consumes 10 to 15 times as much energy as the somatic portion of the body. Think about that one. And so we're talking about energy in the brain. Creatine phosphate is the compound you're trying to make. And that requires methylation. I don't know if you were here when Richard Cunyon was telling you that. But the methylation for energy use to make creatine is the highest demand for methylation in the body. And if you eat creatine, like Jimmy was doing, you reduce the demand for that methylation. So the methyl groups that you have can do other work. So that's one of the advantages of putting creatine in your drink when you're, even if you're not exercising. But it's particularly true if you do exercise. Creatine ought to, a teaspoon of creatine ought to be in there. Okay, I think we're ready for the next one. Cell membranes. The methylation of phospholipids in cell membranes increases their fluidity and ability to receive signals. Cell membranes have receptors like antennae to receive signals. And if the phospholipids in the cell membrane are methylated, they have greater receptivity for the signals that are coming in. Another use of methylation by the body is reduction of allergic reaction. Reduction of histamine to normal balance by histamine nitrogen methyltransferase. A methyltransferase is the methylation of the histamine so the body can reduce it. And when you reduce the histamine, you're reducing your allergic reaction. So if people who have allergies, a lot of allergies, methylation is going to help reduce them.
Is that pretty much any inflammation or just allergic?
But this wasn't inflammation, this was an allergic reaction to something. Inflammation may be involved. And we have the reduction of homocysteine. I call it homocysteine because if you take the E out, you get homocysteine. And that's to differentiate it. Homocysteine is a powerful oxidant that can be detoxified by methylation to methionine. And this brings up a subject of what causes arteriosclerosis in the body. Homocysteine causes arteriosclerosis by oxidizing cells and tissues of the arteries. The artery wall loses elasticity and hardens because of fibrous tissue and deposits of calcium salts that are used to repair the damage. Got that one?
Could you say it one more time?
Huh?
One more time?
One more time. Homocysteine causes arteriosclerosis by oxidizing cells and tissues of the arteries. The artery wall loses elasticity and hardens because of fibrous tissue and the fibrin is being deposited and deposits of calcium salts. And when an autopsy is performed on some people with arteriosclerosis, they need a saw to cut the arteries.
Wow.
There are at least three theories of arteriosclerosis, not to be discussed now because it would take, that's a whole separate subject, but there's a cholesterol theory, which is the fat cholesterol theory. There's an oxidized cholesterol theory. There's the homocysteine theory. And there's Linus Pauling's collagen and vitamin C theory. And that Rath is using now. He developed it with Linus Pauling. However, there is one uniting fact that I uncovered that unites all of these theories, and that is this, that homocysteine is a catalyst for the oxidation of LDL cholesterol. That starts the ball rolling. And then you can bring in vitamin C for repair, and lysine and proline, and then the cholesterol theory fits with that, and that's why the doctor wants you to lower your LDL and lower your cholesterol and all of that, because they're all coming together after that oxidation. So that's a subject for another time. Okay, let's go to the next one. Okay, detoxification. Detoxification occurs in two steps. Phase one of the detoxification process takes fat-loving molecules and makes them water-soluble. These water-soluble molecules are reacted with chemicals that are catalyzed by phase 2 enzymes called transferases that cause the joining together of phase 1 and phase 2 chemical groups in a process called conjugation. The toxins are then excreted from the body. There are 5 types of conjugation reactions: sulfation, using sulfur, methylation, glucuronidation, using glucuronic acid, acetylation, and acylation. That's a mouthful. But you see methyl is in there as well as other things. This is how the body detoxifies everything. And you can see where glycine, glutamine, taurine come in to this. Sulfur is used to grab molecules like mercury. And the supplement that I use for glucuronidation is calcium glucarate. Okay. Any questions on that one before we go to the next more complicated one? Dave?
You mean that some things go down each of those 5 paths, or all those things are happening at once to detoxify?
I think they're all happening at once, depending on what the molecule is that's being detoxicated. The body has a lot of choices for the detoxification, depending on which one fits to what. So all of them are needed, and they're all going on at once. Mostly in the liver. The liver is. This is why Mickey Mantle didn't make it. He died of liver disease from not being able to stand all the publicity. This one is now a little more complicated but necessary so that you understand the protocol that comes next. This is called homocysteine and the SAM cycle. SAM is, right here, is called S-adenosyl methionine. What does the S stand for?
Sulfur.
No.
No.
No, John.
What is it?
Sinister. Really? I'm left-handed. Ah-ha-ha. Okay.
You got me.
Gotcha. This starts with methionine, which is coming from, say, meat, eggs, milk, high protein. Methionine is needed by the body, but in limited amounts, like everything else. Anyway, with ATP, it's converted to SAM, which is S-sinister, adenosyl methionine. You've seen the SAM supplements advertised for depression and doing all kinds of good things, and they're very expensive. This is it.
What's SAM?
It has a little E on the end for distinguishing it from Uncle Sam and things like that.
It's scientific.
Okay, so we're going around here with this. Now we have SAM, and SAM donates. SAM is the primary methylation compound in the body. It does most of all the methylation reactions. Here's a molecule that needs a methyl group. So it comes along, takes it from SAM, the methyl is accepted and it's going out on its way. SAM is then converted into homocysteine, which is the powerful oxidant and the cause of arteriosclerosis, Alzheimer's disease. All Alzheimer's patients have high homocysteine. It's a vascular, with respect to the vascular part of the disease. That's not to say that the metals, everything adds in. Mercury, zinc and iron, John's talking about. But here we're talking about homocysteine in Alzheimer's patients and all heart patients. Now, homocysteine can leave the body by way of cystathionine using vitamin B6. B6, which one is B6? Huh?
Pyroxidine.
Pyridoxine. Okay. Now, here's the main thing. Methyl source and cofactors. The methyl source and cofactors, we need a methyl group added back into this system because we took one out. And it's going to be added in from a methyl source. And to get it to react, you need the cofactors. So here comes the methyl source. It's now demethylated. The homocysteine grabs the methyl group and it's converted back to methionine. And then it goes around again. That's why it's called a cycle. Okay, the methyl source, TMG, what's that?
Trimethylglycine.
Trimethylglycine, 3 methyl groups. Another common name for it is betaine. Choline. Choline, remember I told you before, what's choline? Trimethyl aminoethanol. What's dimethyl aminoethanol? DMAE. Right. Dimethyl aminoethanol. It's a cousin of choline. You need B6 B12, folic acid, zinc, and magnesium. Those are the cofactors along with the methyl sources. In this case, these two are the methyl sources. So that's how the system works. Let's go to the next one. Methyl sources. This is the protocol, methylation protocol to follow. Using the methyl sources, take 1,000 to 3,000 milligrams a day total of any of the three: trimethylglycine, trimethylaminoethanol, or dimethylaminoethanol. Cofactors require B6, 50 to 100 milligrams a day. Don, that doesn't mean more is better? Because...
Yeah, I hope you enjoyed that, Stan.
Yeah, I did. 250, well, some people, if you took 250, 500 milligrams a day of B6, you would end up with a nerve problem. So there's always a downside. There's always an optimum somewhere. And B6 is not required in large amounts. I take a B100 multi-B vitamin, and it's got B6 in it, 100. It's enough. Dave?
Did you find one that doesn't have too much B2?
Too much what?
B2.
B2?
Didn't you say that too much B2 is a problem?
No, B6.
No, before, months ago.
I can't remember.
That was
months ago.
Morgenthaler, Dave. That was John Morgenthaler who said that.
All right. Okay.
John Morgenthaler. That's it.
I also want to point out that this protocol is almost identical to a common one used for ADD and autism in children.
Used for what?
For ADD or autism. The difference, though, is that they actually do kick the B6 up to about 3 times what's here, but only when it's measured to be required. So in those problems, some people undermethylate, about half of them, and some people overmethylate, and they have too much, in which case this would be harmful. I don't know
So you're saying ADD is a methylation problem?
No, I'm not saying it is only a methylation problem. I'm saying this
Not only
treatment helps.
methylation.
So
But sugar's highly involved too.
there's a lot of things going on, but just when people take this, they tend to improve.
That's very interesting. I didn't know that ADD was involved.
What's the point? I missed the point.
What?
What was the point, Stan? What was
This is attention deficit disorder. This is a hearing disorder. ADD protocol is very similar to this. So that there's probably a methylation component of ADD involved. On B12, methylcobalamin. Cobalamin comes in cyanocobalamin and methylcobalamin and hydroxycobalamin. And methyl's the one you want because it's got a methyl group there. Richard?
They said if you had too much mercury, that could be a major problem, right?
Too much mercury?
Yeah.
For,
The methyl mercury.
say it again.
By taking that methylcobalamin, you might end up producing methyl mercury if you have mercury in the system. And that form is pretty bad. Mercury form is pretty bad.
Yeah, methyl mercury is highly toxic,
Yeah.
but it's probably in your liver. I mean, I don't know, it might be in your teeth. Tim?
Yeah, Hal Huggins, he likes to take the hydroxycobalamin rather than methyl.
Hydroxycobalamin.
Yeah, Cunnion says the same thing also.
Okay, so there is something to what you said, Richard.
But why is that particular methyl group any more of a problem with mercury than any of these other methyl sources?
Right.
Yeah, that's the big question.
That's the big question.
In my mind also.
And don't forget, methyl is part of the detox process. So I'm not sure I agree with either one of those.
You know, cyanocobalamin,
Although,
cyanocobalamin is sold by Trader Joe's. 90% of the products on the store shelves are cyanocobalamin.
that's cheaper. It's cheaper to make, I think.
Yeah, but is it safer than methyl?
Well, Life Extension sells methyl. I'm going with them.
Where do you get the hydroxy? I've never even heard that.
Intensive nutrition sells hydroxy.
Okay.
Intensive nutrition sells hydroxy. It's only a little bit more expensive.
Oh, Intensive Nutrition.
Yes.
So there is a third one, hydroxy.
They also sell
It's in the biochemistry book.
They also sell the folic acid at 5 milligrams, 10 milligrams.
Well, 5 milligrams is not much different from 3.2 milligrams. And it's easier to take maybe 5 milligram. Magnesium, 200 milligrams, and zinc, 30 milligrams a day. And you have the protocol for supplying the methyl groups. But that's not the end of the story. Christine, we need one more slide.
I have one question, Brett.
Yeah.
And that is with magnesium. It's said that if it's bound to an amino acid, it's much more effective, as Tom Levy said last month. In other words, magnesium oxide is almost useless, and some of the other magnesiums. So would you recommend like a glycinate or aspartate? Or what kind of magnesium would you take? What do you take, Tim?
Magnesium citrate.
Citrate, okay.
Citrate is the one I use because aspartate could be excitotoxic.
Ah.
Well, the citrate is very low, like by weight. You have to take a ton of it to get any magnesium out of it. It's like, what, 5 to 10% magnesium, the rest is citrate. So you have to take a big teaspoon or a big tablespoon of it to get a very good dose of magnesium.
Okay, that's
So
another
I
factor.
prefer orotate, actually.
Orotate.
Ascorbate means you have to take a bunch of ascorbate, which is a good thing anyway.
The ascorbate is great. Orotate is great. It's more readily absorbed.
What's orotate?
So orotic acid, chelated.
What's orotic acid?
So you can investigate.
The citrate's more acidic though.
I already take a ton of stuff, so I don't want any more.
Solorate makes a brand called asporotate, which is a brand name, but it's a mix of aspartate, citrate, and orotate, which is reasonably priced because straight orotic stuff is very expensive. And it seems to work better for me than any one of them individually. Solorate, S-O-L-A-R-A-Y.
Solorate. Just stay away from carbonate or oxide because those are rocks. And not only are they rocks, they contain lead.
Is there any bioavailability? Is lead, are they bioavailable at all, the oxide?
Very, very little. Depends on your stomach acid.
Or if you take it with lemon juice or something like that, that might help it to absorb, like the citrate. It might help.
I went to my doctor and asked at Kaiser and asked for a homocysteine test. He said, "Look, just take folic acid and you can forget about the test because that'll protect you." Well, my basic question is, if you do that, if you take all those things, is there any estimate of the chances of your having a homocysteine problem such that it really pays, in addition to taking those things, to get a test?
Yes, you still have to take the test.
Yeah, yes, you need to know what the level is. Kaiser won't measure it though. I went to a Kaiser doctor and he told me I was fat. And I told him I wanted a second opinion. He said, "You're ugly too."
Creatine, you talk about creatine. Creatine has been suggested in the life extension literature that creatine may help against chronic fatigue syndrome. Now, chronic fatigue syndrome is something that the physicians have not too much that they can do about it, and it happens. My daughter has chronic fatigue syndrome. So I mailed her some creatine. I got it from the life extension. He says it doesn't fix it, it doesn't cure it, but it sure as hell helps.
Right. There's another question here.
Yes, I'm sure I missed this. When you were going through the methyl sources to say take 1,000 to 3,000 milligrams, you mean one out of those three, or all three of those?
Any of the three or a combination.
Okay. Thank you.
Okay, we go to the last one. And remember, methionine is, the more methionine you take in, the more homocysteine you make. So methionine intake needs to be limited. Methionine is an essential amino acid, but its intake should be limited to 1,000 milligrams a day for a 160-pound person. About 60 grams of protein per day will supply 1,000 milligrams of methionine. Now, if you stop into McDonald's, you're going to get a huge dose of methionine. 60 grams of protein a day. I'm going to show you, that's about a piece like this of any meat or fish, and it's not much.
I can't buy that. I know weightlifters who take 10 times that amount of protein per day and don't have high homocysteine. And I take 60 grams of protein just for breakfast, whey protein, and I don't have high homocysteine. So I'm taking like monstrous amounts of it. Like, I think a diet that low in protein would cause all sorts of health problems.
Okay, well, you can argue with the World Health Organization, WHO.
What's the one you need?
Those are their numbers. Not mine.
He's taking a lot of methylation.
So you must be methylating and detoxifying it.
Could be, I don't know.
Probably.
Okay.
But the average dude out there is not. Doesn't even know how to spell this stuff. Look, excess methionine is converted. Excess methionine is converted to homocysteine. Excess homocysteine is a major factor in arteriosclerosis, Alzheimer's disease, and other vascular diseases. And here, I hope you all got a handout over here of all these slides. The average methionine content of foods in terms of milligrams of methionine per 100 grams of protein. Meat's 2,500. Now, you're only supposed to take in 1,000. So if you want to cut your homocysteine, it's not only the methylating agents, but it's also the methionine intake. If you lower the methionine intake, and these days everybody eats all the protein they want because it goes with having as much, especially if you stop over. Anyway, the seafood, 2,800, dairy and eggs, 2,900. Now, is Jake here? Jake, what's your homocysteine?
Never tested it.
Never got to take it. Jake is one of these guys here, 1,300 vegetables. This is where the vegetable protocol comes in. Getting your protein from vegetables. John's one. What's your homocysteine?
No idea.
You don't have it either.
Where do you get it done?
Huh?
Who runs that test?
It's a normal blood test now.
Any lab?
Any lab, yeah.
The Palo Medical Foundation, I hate to give them a plug, but they do readily test for homocysteine.
Yeah, I get it every time. But they said, oh, your homocysteine is below normal. Forget that.
Yeah.
So we don't do the test. I argued with the doctor. I said, you need to do the test.
Kaiser? You get a Kaiser?
No, I dropped out of Kaiser years ago when I got smart. Anyway, you can see vegetables is the place to go. Nuts and seeds, grains, vegetables, and very little protein.
But if you add the nuts and seeds and the vegetables, don't you get 3,100 then? You add the vegetables and...
100 milligrams of protein.
Per 100 grams of protein.
100 grams per protein.
Okay, this is a good point. Mike is on the macrobiotic diet, using grains, vegetables, nuts, and seeds. His homocysteine is 10, which is at the low end of normal, but still far above 7 or lower.
He's in the 5 percentile.
Huh?
He's in the 5 percentile. In the normal curve.
Yeah, but the normal curve is with heart disease, so forget it. You want to go below 7 if you can. And the 7 I get from Life Extension. They're the ones that promote 7.
What's yours, Dan?
Mine's 10. And I'm avidly working on this one. Because the problem I had, I weighed 27 pounds more than I weigh when I came to Smart Life. And I sat down next to Carl. This is Carl on the end here. And I didn't know anybody, so Carl says, "Did you read The Zone?" I say, "What's that?" And then, so I upped my protein, which cut the, which balanced the insulin, and hunger went down, and I kept losing weight year after year, and never to be gained again.
That's 40, 30, 30.
Yeah, it's too much protein.
Okay.
40 is too much.
No, it's 30.
30 is too much protein. And so I'm working now on minimizing the protein, going more to Jake and Mike.
What percentages do you follow, do you try, and do you use?
Okay, that's it for tonight.
Okay, let's take a 5-minute break before we bring on our speaker, Dwight Jennings. So stand up and introduce yourself to neighbors. Shake the cobwebs out, and then we'll get going again in 5 minutes.